So thank you to all our panelists. First, I'll introduce Patrick Dicerni. Patrick is the Assistant Deputy Minister of Strategic Policy and Planning Division in the Ministry of Health and Long-Term Care in the Government of Ontario, and I'm very fortunate to have Patrick as one of my main interlocutors at the Ministry. Just prior to his appointment, Patrick worked in the Deputy Minister's office, serving as Director of Policy and Delivery since October 2012. He played an important role in implementing the Ministry's policy agenda and delivering on a number of key priorities. During his time in the Deputy Minister's office, he served 2 ministers and provided strategic advice and support to 3 deputy ministers. I'm sure there are a lot of stories to tell, right, Patrick? Prior to joining the Ministry, Patrick held a number of increasingly senior positions at the Ministry of Children and Youth Services, so it brings quite an interesting perspective from multiple positions within 2 ministries. Next up, we have Anna Greenberg. Anna is Health Quality Ontario's Vice President for Health System Performance, and she's responsible for designing and implementing a comprehensive strategy to improve performance monitoring and public reporting in Ontario. Prior to joining HQO, Anna was Director of Strategic Policy at the Ministry of Health and Long-Term Care, where she led a branch of policy professionals in a wide variety of areas, including mental health and addictions, healthcare quality and safety, clinical and social service integration, and reproductive technology. Prior to that, she held leadership roles at Cancer Care Ontario, Princess Margaret, UHN, and the Canadian Partnership Against Cancer. And finally, we have Judy Switson. She joined the Ministry of Children and Youth Services in January 2016 as Director of the Client Services Branch. She's a physiotherapist by profession, and following clinical practice in both pediatrics and sports medicine, Judy achieved progressive positions in management at both UHN and Sunnybrook Health Sciences Centre. Most recently, Judy was Acting Director and Manager within the Ministry of Health and Long-Term Care's local LIN Network Liaison Branch. Without further ado, I'll ask Paul to come up and moderate the panel discussion.
So the topic for this panel is from performance measurement to system improvement. The format is each of the panelists, and we're so grateful you came. I just want to say that there are many reasons why we do what we do, but obviously we want to hear from the people who are key consumers of the information we manage, to hear from them what is the utility of this. So we've provided them with our scorecard ahead of time, given them a chance to digest it, and posed to them 2 questions. They're up on the slide. What is the utility of performance measurement in your role? Relatedly, in what direction would you like data and performance measurement to go to make it more relevant to your day-to-day work? And given your respective roles as leaders in the healthcare system, what are your impressions of the results presented today? Each panel member will have 5 minutes to respond to these, and then we are going to be opening up for questions in the audience. And we also, for the live streaming attendees, we'd ask that you type your questions into live chat, and I will ask your question for you. If indeed we have live chat working. Have we got the thumbs up? We're going to be doing that, so thank you very much. Okay, so I haven't chosen a particular order, but why don't we go from the audience's left to right. So we'll start with Patrick Dicerni, and then Anna, and then Judy. Thank you.
Great, thank you, Paul, and thank you for having me. To respond to the first portion of the question related to the utility of performance management, like most things in government, we like structure around. I'll give you 3 compelling reasons why and 2 enablers or 3 enablers, so I'll structure my answers accordingly. I'd say there's 3+ reasons why the utility of performance measurement is important in my role and as a representative of the ministry. First and foremost, right now and for the last while, in terms of everything that we launch vis-a-vis a strategy, we need to be assuring our Treasury Board and others that we're having some way to measure the goals of what we're setting out to achieve. So in terms of the process and progress that we would look back on and understand that we are actually meeting the goals that are set out in Open Minds and Healthy Minds. With respect to the second one being monitoring system performance and health outcomes. It's more than just monitoring what the outputs of the system are, but how are we impacting the health outcomes of Ontarians and taking ideally a recovery-based view on people's interactions with the healthcare system and taking a truly client-centric and timely, effective, and safe provision of patient care. It plays an important accountability function in terms of how the ministry is able to account for the funds that we put into the system and ultimately are responsible to our decision makers and Ontarians. In terms of that accountability function, and I would extend that into public reporting. Right now, all the provinces and territories and the federal government are engaged in discussions related to new funding for healthcare services in the country, and not betraying any state secrets here, but a component of that would obviously be public reporting, and the federal government rightfully is going to want to be seeing the outcomes of their investments in healthcare, and that's been made clear. I think some of the work that I've seen earlier and that's been presented here today kind of gives us a leading head start on what that performance reporting or indicator work could and should be. That's going to be important to certainly to Ontario in our relationship with the federal government, and I think through the work of ICES, Ontario is really positioned as a leader in this space. In terms of how performance reporting underpins a lot of what we're trying to do with our mental health and addictions data strategy, or mental health and addiction strategy writ large, I'd say that it really does act as, it does support the foundational elements of some of the transformational activities that we're undertaking. And to put a little meat on that, as we strive towards what is going to be a core set of mental health services for everyone across the province, as advised by our Mental Health and Addictions Leadership Council, we're going to be needing to make sure that those services are of high quality and they're accessible to Ontarians. It also is going to help us drive some standardization and fidelity to models that we adopt and endorse and fund. It's also, and the last point I'll make on this is, as we start looking at different ways to fund our mental health and addiction services in this province, we're going to need to really have a clear understanding of what the quality underpinnings of those services are. That's the only way that we are going to responsibly adapt funding going forward. So I really look at performance reporting, quality, as what is the underpinning of what would be any change or evolution of how we fund mental health and addiction services in the province. With respect to the second component of the question, in terms of how is this direction, how would you like data and performance measurement to impact and be relevant in our day-to-day work? I'd say there's 5 things I'd highlight. Some of the scorecard work that we've seen today on the children's side, I think ideally we'd see that as a common provincial performance measurement scorecard across the entire lifespan, linking the children, adolescent, and adult systems. I think that would be reflective of a recovery-based approach to mental health and addictions as well. The next thing I'd point to is some interesting work that's going on between the ministry that our friends at ICES are aware of and involved with, this concept of data linkage or breaking down data across ministry silos and perhaps beyond ministry into the sector silos around. I think your average Ontarian would think that we do share data across our provincial institutions and our provincial ministries in at the very least, the human and social services type ministries. The reality is that we don't. We're in a very siloed data environment. So looking at the Ministry of Children and Youth Services or Community and Social Services, if those programs and services are functioning in a high quality and high performance type way, where are those benefits accruing? Those benefits are accruing to better health outcomes, better educational attainment, and how do we articulate that? How do we show that? And I think the most effective way to show that would be to link our data sets across ministries, and that's some capability that our colleagues at ICES have and have demonstrated in small areas. My firm hope, and this is some work that's going on right now, is how do we scale that up across ministries in much larger data sets to, in a de-identified, anonymized way, really track cohorts and see where our successes and our weaknesses are. I think we need to leverage and build on some of the existing digital health and data assets. The province over the last X number of years have invested a tremendous amount of money in our data and health record infrastructure. How do we turn that from investments into quality and data performance reporting? And I think there's a lot of opportunity there. The last point I'd make is around partnerships, and this touches back briefly to what I was talking about around data integration. I think that beyond what we have internally, we can be linking our data with researchers in this room and community and sector representatives as well to really bring to bear the data that you have in your various institutions and holdings and what the ministry has the more ability to safely and under the auspices of good data sharing agreements that don't take years and years to structure, but that we could get to fairly quickly. I think there would be a lot of value and success there.
Thank you.
Okay, thank you. Really pleased to be here and to have seen the presentation this morning and also to see the progress since 2015. I think that's really exciting. So part of my role at Health Quality Ontario is overseeing the mandate that looks at how do we report on how well the system is performing to the public. And I can say that we couldn't have done what we've done in mental health in this area without a partnership with the ICES Mental Health Group. And it's allowed us to have a chapter in our yearly report on mental health dedicated to mental health. It's allowed us to do a specialized report together on what community mental health and acute mental health looks like together to the best of our ability. And more recently and increasingly, it's allowed us to have sophisticated analysis that is guiding what quality care in mental health looks like. So with our new quality standards program, which happily started with mental health as an area of focus, looking at major depression and schizophrenia, now looking both in the acute inpatient setting and also in the community. It's this type of analysis has allowed us to say where's the major variation that's unwarranted and where are the gaps, and that is leading to evidence-based guidance on what does quality care look like. And I would just say that this is the big link between data and actually understanding quality, which is what does it look like and how will we know when we see it. And I think that this partnership is going to allow us to do that. I would also say that I'm really supportive, and Health Quality Ontario is really supportive of the data strategy that's been laid out. This is building on a tremendous amount of progress that ICES has led. But what the data strategy is contemplating is that we might actually have a unique identifier across someone's lifespan, so that despite different funding streams and different ministries and different data sources, we might actually be able to understand the full picture from a client-centered, patient-centered perspective. That's a fundamental policy change that I think we'd be really supportive of that would advance our ability to understand quality. The second thing, and Patrick touched on this, is leveraging more data systems, not just in health. And ICES has led the way in terms of having linkage with MCSS, social services. We saw today data from MCYS, and I think there's a lot more opportunity there through the mechanisms that ICES has put in place to, if not break barriers in terms of care delivery and funding streams, to use data as a means of driving integration. And we're really excited about some of the advancements in data that we may see. Paul talked about wait times. We at Health Quality Ontario can report on wait times now for primary care, for home care, for long-term care, for acute care, of course, for a long time. We're really looking forward to being able to, on some routine basis, talk about access and timeliness in mental health care. Also very interested in the advancement that may happen in telepsychiatry, telemedicine, telemental health, so that when we're talking about disparities in geography with the North, that we're not just saying we're not sure if this is even an appropriate measure for the North. We could actually look at what is virtual utilization look like, what does community-based utilization look like, and then line that up with what we already know from existing data sets. When I was invited to come and talk to the panel, by coincidence, I was reading an article in the current issue of The Walrus, and I'm guessing some people in the room may have read this article about Tamara, written by her mother. And Tamara had tragically died by suicide. And as I read Tamara's story and the detailed story of the pathway that she had interacting with the mental health system, I thought about the measures that we have in place to understand the client experience and the quality of the care that we deliver. And her first contact was in the ED. She spent 12 hours there. Her next contact with the health system was 2 weeks later, and then there was a series of different contacts. There were several weeks out, then another 2 weeks. And her mother described that agony of those times in between and this sense of abandonment and not knowing how or when she would find stability, and the length of time it took to actually feel like she had a complete diagnosis. And I just find when I look at this data, there is so much that we can see, and you can see actually a reflection of Tamara's experience in the data that we see today. But we also don't hear from what that experience feels like from the perspective of the clients and the caregivers. And so I think there is an opportunity, and I know there is opportunity with tools like OPOC to, in the future, understand that kind of client-reported, patient-reported measures. Ultimately, Tamara's mother ended up, not ultimately, but before the tragic passing, Tamara's mother had her daughter arrested so that she could find the care that she needed, and she found stability through medication in hospital. But then she talked about not having a robust discharge plan when she came out again. And I think the data that we're seeing today in terms of 7-day follow-up and your chances of getting that 7-day follow-up really speak to that robust discharge planning that is really needed when someone might get to a point of stability. What jumps out at me when I look at the findings today, we are definitely seeing that more kids are needing care. And we see their use not only in the acute setting, ED and hospital, but also in outpatient physician visits, both rising. And what's really striking to me, and this was pointed out, is that where we see that increase happening in both outpatient and in the acute setting, we don't see that 7-day follow-up changing. And we would like to see that 7-day follow-up changing because you want to know that on the other end of those interactions with the acute care, that there is some follow-up plan and that you aren't just having ED return visits or readmissions be kind of standard of care. Of course, we also know that follow-up care may not be with a physician. And so we have the beginnings of a glimpse of what does the community access look like. I will say that when I look at some of those wait times and I think about Tamara's story, I think about something like a 35-day wait or a 98-day wait, which may not even be, you might even have, we know that some patients are waiting a lot longer than that. That just sounds like agony when you put it together with a personal story. I also think about the equity dimensions that the team has thoughtfully included in the analysis and thinking about geographic disparities, income disparities, and it does make you wonder where is the unmet need, who's not being served, and it's likely that those patients and clients do end up back in the ED, and we see them in kind of the ED first contact data, but it does make you want to understand who aren't we serving when you see this rising demand. I also think that what we don't get enough of a picture of, and this is something I know we will be able to do, is the effectiveness of care. And what I'm hopeful of is that if we understand, if we marry this analysis with the quality standards in mental health, taking just major depression and schizophrenia as two examples that are opportunities now, that we could advance the data in line with what does quality care look like, and we could understand a better picture of what does effectiveness look like, things like the transition that should happen after an episode. I also am struck by the important insights to the opioid strategy when we look at the neonatal abstinence syndrome data. We've heard from prescribers the need to really understand the different types of patients and clients who need pain management, may be at risk for opioid use disorder, and I think this particular population, looking at teen moms in particular geographies at higher risk, is a really important and valuable input to what the support should look like for the opioid strategy. So overall, really, really interesting findings. And I just want to say a big congratulations to the group because I think there's a tremendous amount of progress. I think Ontario's lucky to have this kind of data infrastructure and analysis, and I think we're already seeing it informing policy.
That's not why we invited Anna to present, but everything she said before was very meaningful. Judy, thank you.
I do want to speak a little bit about the journey that we've been down in MCYS with respect to data. But just before I do that, I was asked to speak to the utility of performance in my role. I'm going to speak again here to a little bit about MCYS because I think we are a bit of a unique ministry in that we have a regional office structure which has given way to a LIN structure in health. And the structure in MCYS is such that our 5 regions report dually up to 2 ministries. And our ministry is very new. So having come over from health into MCYS, I was used to a relatively rigorous and robust environment of data. And I came in here sort of expecting a little bit of that, but very quickly learned that the journey that MCYS has gone down and the journey that is now being part of a conversation between MCYS and health, and a very positive conversation, has been, it's a journey worth telling. So I'm just going to spend a moment just walking you through that a little bit. The data strategy in health, or excuse me, in MCYS has been underway since about 2011 with an Open Minds, Healthy Minds as the name of the strategy, followed very quickly by a transformation agenda called Moving on Mental Health. And the reason, or the raison d'etre for this, was really based on an understanding of a tremendous need out there. And a lot of the data that we've seen today represents that need. It's about consistency across the province, understanding where services are, what services are, understanding how to navigate those services. And those are understanding that there's a consistent approach to data and to standards and to expectations on behalf of when you go, you know that you can expect a certain standard of care from various providers. So starting with an understanding of that need, there was a robust exercise underway to say it's one thing to know about need, but we need to be able to measure in some way. And that led to a consultation and collaboration that resulted in the identification of the performance indicators that you saw rolled up, or it's rolled up in as part of the report. We have identified at this point 13 performance indicators, of which we're vigorously reporting on about 10 of them. And underpinning these 10 was a first initiative to understand, it's one thing to say that you need to measure, but we needed a consistent set of what we are measuring against. So there was prior to the development, or concurrently with the development of performance indicators, was an identification of core services. So we have a series of core services, 7 core services. We have some key processes identified. We've attempted to create definitions and expectations of those, and following out from that, we have gone into our performance indicators and our performance measurement. So I know I'm talking a little bit lengthily, but at this moment in time, we have about 2 years worth of data that we can report on. The data that's in the scorecard now is our first year's worth of data, and although we're very proud of that data, obviously 1 year's worth of data is not a strategy by any sense of the word. We have launched an exercise to start sharing that data, so we've created a system of providers through our lead agencies, 31 of 33 at the moment, and we are starting to share our data and do training for our providers so that they can understand what is behind the information that they're looking at. And again, when you come from an environment where this is new information, and it's a new approach, and a new lens. It's a very important part of developing the sector as we move forward. Very quickly upon identifying performance indicators was an identification that our indicators were not necessarily as robust, or they weren't necessarily speaking to what the providers needed in order to be able to report on their activity and what they considered to be success in what they were doing. So we've got an exercise underway to refine those indicators, and that will be an ongoing and an iterative process. We also have undertaken the implementation of a business intelligence solution, and this will be a robust system to actually capture our data elements and give us that freedom and flexibility to create reports that respond to need. I think the final point that I want to say here is that part of our journey and a very critical part of the journey going forward is the movement of our strategy into health and to include addictions. And the second part of that is the working relationship that we're establishing with health and an ongoing relationship with education, just in order to create that journey rather than simply looking at silos and in isolation. So just in conclusion, we were asked to speak to our impression about the results today. And I, like Anna, I think mental health touches many of us in many ways, and I'm not excluded, so have the experience. And in many ways, I look at the information that's been presented today as a bit of a good news story, because I think mental health illness is being destigmatized, and I think it's wonderful that we're creating a safety network so that people feel that they can come forward and seek the help they need when they need it, so critically important. But I also think the statistics report to what we all know, and that is that the journey is really in its infancy. And I think the success factors that underpin where we're going relate to our ongoing connections across our ministries. They relate to our commitments, which I think are demonstrated here today. Our lead agencies are the Connect for Children and Youth Services, with the other agencies, with LINS, with education bodies, et cetera. And we need to, as leaders, ensure that those connections are maintained and developed. And again, I just want to go on to say that data is one thing, business intelligence is another thing, but it's what you do as you develop that data and how you use that data that is important. So when I see these scorecards, you think of the art of the possible about where this can go in order to inform all of us as we march down this journey together. And I think about moving towards benchmarks and targets within my own ministry, and be able to start speaking to those and looking at performance against those across the province to allow us to continually develop the system and allow us to inform where our policy has to go in order to continue to improve the system as we go forward. I think the one final thing that I will say is, and Anna or Patrick did mention this as well, it's one thing to speak about a child and a youth. It's another thing to speak about obviously a person throughout their life. And so one of the key things that I think we need to think about going forward is that ability to track the trajectory of a person as they move in and out of care, in and out of sectors, not silo ourselves, but make sure that we have in mind that we want to be able to look at the person and their journey, not necessarily at what MCYS does, what health does, what education does as we move forward. So it's been a very enlightening, and I'm very happy to be part of it. So thank you very much.
Thank you, all three of you. I just want to thank you very much for agreeing to